Warm greetings from Nepal. It is my great privilege and honor to be here. Thanks to Professor Fan and colleagues of the China Anti-Cancer Association (CACA) for your invitation and great hospitality in beautiful city of Siam. Thank you, Chairperson. Ladies and gentlemen, in breast cancer surgery, there has been a paradigm shift from hasted radical surgery to breast-conserving surgery or lumpectomy over the past 4 decades. However, lumpectomy is performed in fewer than 20% of breast cancer patients out of the approximately 40% early stage cancer in Nepal. Today I will discuss breast cancer surgery in Nepal, lumpectomy versus mastectomy, a case-based approach. Nepal is a small, lower middle income country between two giants, China and India, with approximately 30 million people and a female population of 52%. In Nepal, the literacy rate is 70% and the GDP per capita is 1336 USD. Total health expenditures are only 4% of the GDP and per capita health expenditure are 58 USD. According to Globocon 2022, breast cancer is the most common cancer among women in Nepal, followed by cervix, lung, gallbladder, and stomach. Breast cancer is the most common cancer in women worldwide, also in Nepal. There is a significant disparity with a 5-year survival rate of 90% in high-income countries and only 60% in low-middle income countries. This disparity is because of late diagnosis, inadequate service, and low coverage of cancer care. Breast cancer is common in age groups after 50 in the West. In our part of the world, the most affected age group is 40 to 49 years, comprising 34% of the cases, with 75% of breast cancer cases occurring in the age group 30 to 59. Screening is crucial for this age group, particularly for women under 50 and those who are premenopausal. We do get breast cancer approximately 20% in age group less than 40, which is much higher than in the West. Regular mammography, the most common screening tool, is especially beneficial in women more than 40 or at high risk. This is crucial for several key reasons: early detection, better treatment options, improved survival rates, preventing advanced disease, awareness and prevention. We have 30 mammography machines in Nepal and mainly available in the central region. This is only half of the minimum recommended level in the country. Addressing the shortage of mammographic machine is essential for promoting breast-conserving surgery or lumpectomy and improving breast cancer outcomes in Nepal. Let's explore the historical perspective of breast cancer surgery based on the principle of breast cancer as localized disease. Historically, surgery was the first curative treatment for breast cancer. For breast cancer, advocated by the Greek physician Galen nearly 2000 years ago. In the late 19th century, the advances in general anesthesia and antiseptic techniques led to extensive procedures, the era of half-shed mastectomy. The breast-conserving surgery in 1970 and sentinel lymph node biopsy in 1990s. Now the concept of lesser resection with a better cure has been widely accepted. Since Halsted reported a radical mastectomy in 1894, surgery for breast cancer has undergone de-escalation in its radicality thanks to many landmark trials. Breast-conserving surgery or lumpectomy has some unique benefits of organ preservation and lower psychological impact. Lumpectomy with radiotherapy is a global standard of care. In low-resource settings like Nepal, mastectomy is often chosen for early breast cancer due to practical and systemic challenges like limited access to radiotherapy, financial constraints, and limited diagnostic and follow-up capabilities. Additionally, a single surgery approach is cost-effective in low-income countries like Nepal. In Nepal, breast cancer surgery is primarily performed by general surgeons. The preference of general surgeon for mastectomy and breast surgeon for lumpectomy often stems from differences in training, experience, and familiarity with evolving treatment guidelines. This may contribute to the low rate of lumpectomies performed in Nepal. Our post-operative data shows that approximately 40% of cases were early-stage breast cancer and 2% were non-palpable breast cancer. However, the majority of patients presented with localized or locally advanced cancer. We have not included the data on metastatic or non-operative breast cancer patients. Modified radical mastectomy was the most common surgery, while breast-conserving surgery (BCS) was done in 19% of the cases. Oncoplastic breast-conserving surgery was performed in 3 patients, wire localization and lumpectomy in 3 patients. This finding of BCS initiated an analysis of lumpectomy versus mastectomy scenario in the country. This is our report on simple oncoplastic breast conserving surgery for 22 early breast cancer patients. The median age of the patient was 43 years and the median tumor size was 2.5 centimeter. Simple oncoplastic techniques such as radial ellipse segmentectomy, round block technique, and batwing technique were employed. Sentinel lymph node biopsy was done in all 22 cases with methylene blue. In this series, sentinel lymph node positivity in 1 patient and non-staining of lymph node in 2 patients. All patients except one elderly patient received whole breast radiotherapy. One case showed margin positivity and was re-excised. No loco-regional recurrence and 100% 5-year survival in this series. Mastectomy is the most commonly performed surgery in Nepal, with only 20% of patients undergoing lumpectomy. The cost ranges from 150 to 250 USD in public hospitals and is somewhat higher in private hospitals. However, surgery is the cheapest treatment modality for breast cancer in Nepal. Breast conserving surgery typically requires adjuvant radiotherapy, but access to these services is limited, with only 11 centers, 5 public and 6 private, mostly located in central region of Nepal. RT is scarce, has a longer waiting time, and costs more than 1500 USD. Younger women are increasingly choosing lumpectomy over mastectomy due to various factors, including cost and personal preferences. This preference is often influenced by several factors such as cosmetic outcomes, psychological concern, and a desire for less invasive surgery. Younger patients are generally more aware of the available treatment options and outcomes. To summarize, the factors influencing the choice between lumpectomy and mastectomy in Nepal include tumor size and location, patient's age, access to radiotherapy, psychosocial consideration, and overall outcomes. Financial factors are especially important, as the lack of an insurance system, the need for out of pocket payments, and inadequate financial subsidies create significant barriers. In conclusion, both lumpectomy and mastectomy have unique benefits and risks. The choice depends on multiple clinical and personal factors. Although lumpectomy is performed in fewer patients, there is a significant room for improvement in diagnosis and treatment in Nepal. Thank you for your patience listening. like, share and subscribe.